I have to say, it's always an honor to come talk to these because as a cardiovascular pathologist, you're kind of seeing not only the development of devices, but you like, I think if you're a good pathologist, to have your hands in their development and give a lot of feedback to input. And you just see the way things change. I mean, just the fact that you're talking about wiring technology and wiring abilities. When I was a resident with Chad, wiring ability meant how successful were you at getting your parents to send you extra money so you could live while you were training. So things are definitely changing. And what I'd like to talk about this morning is a little bit of just kind of show you what the potential pitfalls and struggles with aortic valve pathology, and also talk a little bit about mitral valve pathology, and kind of show you what these things really mean, and how, at least from my end, I assess what happens to these patients. The caveat is that when you're a pathologist, you select out a certain portion of the population, and those are the ones that have passed away. So while I will show you some complications and various outcomes, obviously I have a certain pool that I see, but I think the message behind what kind of aspects you have to account for in assessing your patients and what are the challenges moving forward are nicely illustrated by a lot of these cases, but certainly they don't reflect the high number of successes. And the reason why everybody's here today is because this is a very exciting and promising technology that I think is, as everyone will say, is only going to grow in its ability and its use. So there's a lot of topics that do need to be covered and touched on in a small amount of time. Not only the normal anatomy, but what happens in disease of these valves. How do they look? How does it form? Is it uniform, which it's not? What are the different functional differences and how they present differently in terms of the valves you'll be treating? The changes in the heart overall, which then also feed back onto things like morphology and success rates and outcomes. I'll look a little bit at specific pathologies that we found in some of the TAVR cases here and how they reflect to what you'll see later in terms of design and expanding the pool of patients that undergo these procedures. And then I'll end with a little bit of contrast looking at the mitral valve. So all the things that I'll talk about in the aortic valve, you'll see how the mitral differs and how that therefore brings its own pool of challenges with it. So anatomy is, I think, the course that most people are happy to leave behind once you get out of medical school. Nobody likes to be grilled about the various muscles of the lower jaw and all of that pain, but as you do specialize, you find out it really is the basis. So at least for the aortic valve, it's a very interesting situation in that you have really a distinct valve that sits within a tube. It's suspended. You can see within this fibrous sleeve that basically links the aortic root to the ascending aorta. It's kind of woven into the two and has somewhat of a different histology, so it does react differently if you place something in it compared to, say, endovascular repairs of aneurysms or coronary stents, although a lot of the concepts do overlap. But in looking at this anatomy, you can see why it's a really nice target, and it's kind of the way Steph Curry looks at a basket. This is the way an interventional cardiologist would look at a potential site for valve repair. The sinuses of Valsalva even themselves have a difference between how the coronary sinuses react both in the natural setting and in disease. So there is, even within what looks to be kind of a uniform valve, there are differences within, and they accept stressors differently. It's a nice image of the coronary anatomy and an aorta from a patient that has been opened to show you the valve leaflets. You can see how they insert into the aorta along the ridge, and that there is a fair amount of overlap. And so in this valve, which is essentially normal, you do see that there are a fair amount of areas of fibrosis and thickening, and these are just normal. From even normal flow, you're going to have areas in which there's more fibrosis, somewhat unevenly deposited, and this also will affect things like contact points if you place a stented device across it. So again, there's not uniformity, even though if you just kind of draw it out, everything looks like it's the same from one cusp to another and from the top of the cusp to the lower. There's definitely differences in the structural structure of the cusp, but also on the forces that are applied across it. One of the common views I think is important is to look at the relationship between the valves, because when you're working in this area, whether it's a surgical approach or a transcatheter approach, what you do in one valve affects the other. So on the left-hand side at the bottom, you see the mitral valve, how it's closely opposed to the aorta in the center, and then also the tricuspid on the right, and then the diagram illustrates that you not only have to think about these things in 2 dimensions, but you have to think in 3 dimensions as to what structures are lying below and what is running around these valves from both a pacemaker standpoint and a vascular standpoint. All of these structures, and any time you implant a device, have the potential to be affected. And then also down the road, you think about all of these structures are potential access sites. So, the coronary sinus can be an access site to actually implant a device. And we just saw the IVC being used, and I've worked with groups that are looking at implanting essentially stents in the IVC, and that has its own list of risks and rewards. The aortic valve is really an elegant design. Like most things in the temple, it is designed for long-term wear, and considering how many patients get through life without either being diagnosed or experiencing significant valvular disease, it really is a tribute to how this valve is designed. It has 3 main layers that have different functions. The ventricularis layer, which is on the lower surface facing the ventricles, is really the layer that provides the valve with its ability to endure 70 beats per minute for how many days and how many hours and how many minutes this heart is working. It contains elastin, which allows it to tolerate stretching and force, and obviously then injury to this elastin by some of the processes that we talk about can help start the snowballing of valve failure and remodeling. The spongiosa, or middle layer, is really the shock absorption. It's complex in its composure, and it is certainly also prone to change with alterations in stress. And then finally, the fibrosa layer provides really some of the physical strength, and is composed of various types of collagen fibers. And then also the annulus, or anchor point, which is fairly uniform compared to the mitral valve that I'll talk about a little later, around the circumference. So we've got an area that is set up to endure stress. It's got a nice fibrous skeleton to it, and it really is a good area to deploy stents and other mechanisms of holding devices in place. And this is what it looks like under the microscope. On the left side is an image of a valve. The upper surface is actually a little bit of sclerosis, because, as I said, I don't see a whole lot of normal valves. And even when you look at valves from patients who come to autopsy for death by other reasons, it's not unusual if they're at a certain age that their valve will show already the onset of some disease. One of the lectures I give every year is talking to the medical students about atherosclerosis, and I show them a slide that points out that for most of us, atherosclerosis begins when we're in our early teens, and it scares them, and for about a week they go and eat a lot of salads, and then they go right back to screwing with their arteries. But the other aspect that's demonstrated here are some of the forces that occur during systole and diastole. You've got a valve that both has to basically compress every time the heart squeezes, but then also tolerate this backflow of blood when the heart relaxes. And so the coronary cusps have a little bit of a pop-off with the coronaries, which the non-coronary does not, and that can explain to some extent why disease may affect the non-coronary cusp more than others. I won't delve into the years and years and years people put into determining why sclerosis and stenosis occurs, but I'll just touch on some of the points that affect the process of this disease. So in many ways it is similar to atherosclerosis, where we think that it's partly an injury and repair model, but in some ways it's not. But there is endothelial inflammation and injury having to do with both local injury and then just systemic blood pressure and inflammatory states. Again, the non-coronary cusp and flexionaries near the base do see more stress, so they are more prone to injury, and oftentimes you'll see that disease will start and be accelerated or be more severe in these areas. So again, when you're thinking about deploying a device, you have to recognize that it may not be a uniform distribution of disease all around the circumference, and you'll have to consider that certain areas may require a little more attention than others. Angiogenesis is a key component here. In almost every valve I see that comes out of patients or at autopsy, you find areas of significant ingrowth of vessels. That brings both the possibility for more accelerated healing response, more inflammation in response to device placement, as well as hemorrhage, which is a frequent finding in any valvular intervention. And then calcification is key, and I'll show you some images of calcification, and we'll have some in the wet lab so you can see just really how prominent the calcification is, and appreciate how it's something that does have to be accounted for and dealt with when you're deploying a device across the aortic valve. And then I'll show you a little later how it differs in the mitral and has its own essentially set of concerns. But I'll also show you how the mitral valve, when it calcifies, can mess with your ability to get a nice placement on an aortic device. The calcification in valves actually starts very early in the process, which is a bit different from what we see in arteries. It recruits osteoblasts, so it's not unusual when I get a valve that I actually find bone in it. So I may get a valve that's calcified. When I look at it, it's got pieces of bone and may even have bone marrow. So in some extent, when it's got marrow, it kind of cuts out the middleman, can make blood and drop it directly into the bloodstream. This is a nice diagram just to show you the process and show you how complex it is and how progressive it generally is over time, and the different features that occur. And it's always nice to put up an image to make people think that you are smarter than you are, because it looks really complex, and it is. But the take-home is just that this is a very progressive and destructive process, and so the valves that are diseased are very different from the native valves, which is somebody who also works with companies in development. You always have to keep in mind that a normal model in animals can be very hard to extrapolate. This is what they look like. Sclerosis is the term we use really for just thickening. It does come with some degree of mobility impairment. It generally is not as severe as what we see in clinically stenotic valves, a little less involvement of the commissures, but any amount of fibrosis and calcification can be present. And then the numbers looking at it suggest that of patients who have sclerosis, about 1 in 4 to 1 in 5, as I think more the current number, will progress to have more severe disease, like this valve, which is a stenotic valve that has many of the features that make dealing with these through a transcatheter approach a real challenge. You can see the degree of calcification at the lower portion of the valve. You see the kind of typical nodular calcification that we see within sclerotic valves, but above you see we've got this mass of calcification. It's basically obliterated the commissure, so you've created, if it wasn't to begin with, you've now got essentially a functional bicuspid valve. You've got this fragmented calcific mass, and that's going to be affected if you place a stented device across it, both in terms of restricting what your stent can do, but then if you are blowing up the stent to help placement, what's going to happen to this lesion? This is what these look like under the microscope, and they're as impressive, I think, histologically as they are grossly. On the left side, it's more of a purely fibrotic or sclerotic valve, where you see kind of the central portion is a little bit more typical valve. That the spongy layer or spongiosa in the middle is pretty much obliterated at this point. We don't really have the same degree of shock absorption. And then you see layers of calcium and fibrous tissue beginning to form. And then on the right, this is just a very typical valve that I see that comes out of patients with bicuspid valves or calcified even tricuspid valves. And it shows you just kind of the nature that this is complex calcification. When we look a little higher power, on the left you can see the neovascularization, and in fact there's already been evidence of subacute hemorrhage going on in this valve. So they're very dynamic lesions as well. So not only is the process producing fibrous tissue and calcium, but you can't think of these as basically just kind of permanent lesions sitting in the bloodstream because they are subjected to all this force. They do undergo much change. And on the right, this is a scanning electron view just to kind of show you the erosed surfaces of these valves and why in part they can be problematic. But in some regards, the other thought is that some of these changes actually probably help a little bit in terms of avoiding pitfalls when placing a transcatheter valve. So on the left side, essentially a normal valve, showing you the cusps with the arrangement along the sinotubular junction, the membranous septum, the association with the mitral valve, anterior leaflet, and in green you see the left bundle branch. And that part you need to take with the biggest grain of salt, because one of the things you find when you look at these valves is there's really marked variability between where the bundle of His runs, where the bundle branches run when they first come off, and this variability actually either helps or hurts a patient in regards to their chance of developing post-procedural arrhythmias. And unfortunately, at this point, there's really no way to know where it runs unless you can actually take it out and look at it, and that is an opportunity, I think, to help stratify our patients for risk for post-procedural arrhythmias and potentially need for pacemaker implantation. And on the far right, you see a core valve showing essentially the desired implantation. And you do see that the ventricular struts really do abut in the area of the distal bundle of His and proximal bundle branches. And no matter where they come off, there is the potential for interaction. And the other thought is that, even if you have a specific form of the disease, not everybody is created equal. And so you have to consider when you're putting these in that all of the different disease processes that may get you to a stenotic valve or a calcific valve actually can have very different presentations in terms of what's the disease in the valve look like. So congenital valves certainly can have a wide range of how they look, and then even bicuspid valves. So what we call bicuspid valves, depending on Seaver type and the degree of calcification, present a very wide spectrum of challenges for deploying a device across these valves, because they'll have different degrees of opening of the commissures, different degrees of non-compressible calcium, and then rheumatic valves are their own picture as well. So rheumatic valvular disease, obviously it's post-inflammatory. Initially these valves, when you get them, and it's rare to get them, but occasionally I see one that's kind of in the midst, they're very edematous, they're inflamed, you see lots of necrosis, and it really explains how they look late, which is extensive scarring. They usually do have commissural fusion, and then again they're also associated in other valves with fusion of chordae, so they really can have marked changes in the structure and anatomy, and also their relation to the ventricle below. So here's an example of a rheumatic valve. You can see on the left a very tight stenotic lesion with fibrosis, a commissure that's completely fibrosed, and the elastin stain on the left, on the right, shows you what's really happened. The top is the aorta, the leaflets are coming off, and then what should be open commissure has been filled now by a fairly dense fibrous tissue that clearly is going to affect, if you place a device across this, just how these leaflets will be compressed up against the aorta. And you also have to account for the rest of the heart. And very typically when we get these hearts, the first thing you notice before you even cut into them is they're abnormal in shape and size and thickness. You can feel many of them will have hypertrophy from aortic stenosis. Basically, the heart is like a muscle. Anywhere else, every time it pumps, it's another rep. And so if you up the workload on it with a stenotic valve, it's not surprising that these valves can get very thick. And again, I've got some examples for those of you who stop by the breakaway session to look at some gross specimens. And then over time, you get into more of a failure picture with apoptosis, and it's obviously a complex process, but you can go from basically hypertrophic to dilated and scarred and low ejection fraction states. The other concern, because this is the area that you're operating in, is that valve dysfunction affects the ascending aorta. And it can be a pretty remarkable effect, and obviously no one knows better than Chad the link between valvular disease and aneurysmal change. It comes from many different areas. Both there may be an underlying connective tissue issue or inflammatory issue, but then there's also the effect of altered flow. So with stenotic valves, the jet effect, it's basically a garden hose where you're tightening down the nozzle, so the blood flowing through has quite a bit of force, and typically we'll see, even if they're not appreciated clinically beforehand, you see that there are saccular posterior thinning of the ascending aorta. And then also there's just a generalized injury, which we call medial degeneration, which is replacement of the nice, normal, smooth muscle and elastin laminations in the in the aorta with just ground substance. And so here's an example of a regurgitant valve. You see here we've got more, instead of fibrosis, we've got increase in myxoid replacement. The ends begin to roll, very typical for regurgitant flow. And here's an example of aortas. Both of these hearts are actual TAVR patients, and you can see on the left, this one just has a fusiform enlargement of the ascending aorta. And then on the right, even more tortuous to the interventionalists, there's a saccular aneurysm kind of sitting just above where essentially the distal margin of the replacement valve would go. So there's multiple things to consider just traversing the valve to get to the location where you want to deploy it. This is an example of the aorta in one of these cases, showing in aortic regurgitation the loss of the normal laminations. You can see on the right-hand side, this is a a MOVAD stain, which breaks down the different components. The elastin is kind of dark black, the smooth muscle is red, and the green you see is all this ground substance that has accumulated. So basically all the components that allow this aorta to stretch and return back to shape have been markedly disrupted in this one patient's aorta. So when we look specifically at the valves from a pathology standpoint, the kind of two basic things we look at are what is the effect of the local tissue, of the valve structure and the changes on how the implant was placed, and then secondarily, what's the effect of the implant on the surrounding tissues and the longevity of the valve. And the heart on the left is actually from I think about a 24-week stillborn that shows you another version of a loop where the ventricle in this case remained tubular. So this, like most medical students, this patient never grasped embryogenesis and actually remained in this state. From an autopsy standpoint, the things we look at are what can go wrong. Is the placement correct? Do we see evidence of if there was clinical leak? Do we see why that may have been? What does this device look like in situ? Evidence of myocardial ischemia, either predating or potentially related to placement. Arrhythmias, we will look to see where the conduction system is and see if it correlates with the arrhythmia. Underlying cardiomyopathies and the degree of leaflet changes, and try and link that back to what was the outcome in these patients. So early on, what do you look for? You look for the shape of the device. Is it deformed at all? Most of them do have some deformation, but it's not functionally significant. And we look at the leaflet compression. What happens to the underlying valve and where does it go? Can we learn things based on patterns of calcification and fibrosis that are potential red flags as you try and select which patients and figure out prognostic features, and then just changes to the valve, to any calcification in it, and looking for thrombosis that may be associated. So here's a valve in a patient who died relatively shortly from other problems, but you can see nicely placed, sitting well in the aorta, and this is kind of what the starting point and the gold standard. The complications, again, that I talked about, you're all kind of well familiar with. Just the two things I would say: we look for arterial trauma to rule out issues with placement, and then other things that may not be suspected. So it's not unusual that, especially in older patients, we find they have significant cardiac amyloid that was completely unappreciated. And if it's sitting in the middle of your conduction system, these patients are at risk for sudden death regardless. And I don't lecture about it around the country, but I do testify about it around the country because I can tell you I get sent cases to review of periprocedural deaths where cardiac amyloid probably explains a sudden unanticipated death, much to the chagrin of plaintiff attorneys. We talked about the plaque and what can break off. This is just an example of a study that was done that actually deployed a device to capture material, and you can see that there's just a wide range. These embolic issues, certainly there is a risk of stroke, but in the majority of these patients it was just completely asymptomatic, but a wide range showing you kind of that these are a little bit traumatic. Looking at the rest of the heart, and again I'll have some examples upstairs, you have to remember that the ventricles are not normal to some degree, and on the right side these are cross sections of coronary. And if you stare really hard at the upper one, you can see it at about 11 o'clock. That's the only lumen this patient was living off of. That was the right coronary in this patient, and below it is the LAD. So this patient was certainly not going to do well with a surgical approach given the degree of coronary disease. And this is the valve in this patient looking pretty good in terms of placement and shape, and the leaflets all looked good. Here's an example of calcification and its effect. This was a valve that Kevin called me before and said, you know, everything seemed to went well. We had a perivalvular leak. We were ballooning. We couldn't really get rid of it. And when we looked at this valve, you could see, looking from below on the right, that the mitral anterior leaflet had this big chunk of nodular calcification on it that the nitinol just couldn't really wrap its head around, so to speak, leaving above and below these areas of paravalvular opening. So it's a case where your mitral anatomy is actually affecting the placement of the aortic device. Another example of the mitral messing up its neighbor. This was a patient that died shortly after, was found to have hemothorax and hemomediastinum. Everything looked kind of good initially on the left, but you can see again that anterior leaflet of the mitral has this nodular calcification on it. And when we remove the valve, you could see that in deploying the valve and ballooning it, because the calcium has really no give, there was a tear created that was the source of hemorrhage. This is a sapien valve showing an obstruction of the right coronary artery, and there was evidence of ischemic infarcts distal to this lesion. And then late complications we look at, which is more what the response of the body to the valve does to the valve. And the valves are essentially stents, and stents are kind of like the Donald Trump of vascular medicine. So they promise to make the lumens great again, but in general, they're irritants, and the host must learn to tolerate them. They're very hard to pin down, and they often require force to do so. And then they're also known to exude noxious substances. But generally, life would be a little bit more boring without them. And that part you can edit out depending on your own personal belief. But we look for things like pannus overgrowth, prosthetic tissue sclerosis, and then also endocarditis, which can be a late complication. Here's a very early pannus overgrowth. You can see it's just beginning to overgrow the commissures, that white tissue. It's similar to neointimalization of coronary stents. The leaflets themselves still look good. But here's another valve that came out. You can see in this case, looking directly down on it on the left, there's significant thickening of these leaflets. Mobility was clearly limited. And when you look from a side view on the right, you can kind of see how this tissue is building up in the cusp area. This is a valve in valve with a sapien valve. And when you look down at it, it's not hard to appreciate that there's thrombus forming in these areas. And so it may be a combination of both pannus overgrowth and thrombus with subsequent organization that's going on in these valves and limiting some of their functionality. And here's a case of late endocarditis with some fibrosis. So I did want to touch quickly on the mitral valve and its specific challenges. Obviously, that's already been talked about a little bit, but there's differences in the shape and size of the valve, the structure of the valve, how it's put together, how it's attached, and how it relates to the surrounding structures, things like the coronary sinus, the aortic outflow tract, the AV node and bundle of His, and even coronary arteries are all subject to forces on the mitral valve. The shape of the valve is a saddle, so obviously this is not as easy a location to place a device across and have a uniform fit and function. The commissures are the low points, and the valve shape can vary too. The more myxomatous the valve becomes or floppy, the flatter it becomes. So maybe that end of the spectrum may be more readily dealt with. The size, as said already, is larger than the aortic valve, but it's also not static. During heart function, portions of the annulus actually contract. So here's just a side-on view looking at the valve and the anterior leaflet to the far right and the posterior towards the left, and the chordal attachment, so it's a very complex structure. The location I talked about, showing here just some of the structures around it that you have to consider as well. So again, we've got conduction system issues, we've got vascular issues, and then you can see with its continuity with the aortic valve that what you do to the mitral can affect the aortic outflow. Here's images from a patient showing, if we look at the right side first, you can see where the mitral actually plugs in at the top, the central fibrous body, and then the bundle of His down near the bottom. So you can see it's really only a few cell layers deep to the surface. So depending on the design and deployment of the device, it's not hard to see that this could be compressed, leading to some degree of AV block. And then on the left, showing the AV node is sitting up in the atrial portion, but also can be subject depending on where it lies. And there have been studies looking at where the bundle of His exits, how deep it is in the central fibrous body, and showing that that has a direct effect on the percentage of patients who will develop post-procedural blocks. And then I'll end just with showing you a couple examples of what these look like. Again, some of these will actually be upstairs this afternoon if you want to see them. But this is a valve in a patient with a long history of mitral prolapse, who actually probably died with mitral prolapse, had no other findings. We don't like to make that diagnosis unless we absolutely can't find anything else. And this patient was worked up for channelopathies, and everything came back negative except for this markedly abnormal valve where you can see the thickening and ballooning, but also on the right you can see some chordal fusion and fibrosis, so a markedly abnormal valve. They do look obviously different than the aortic valve, both in normal state and disease. And then this is a rheumatic valve showing its own set of challenges, very fibrotic, very hard to place something across this annulus, not only because of the leaflets themselves, but on the right in a view from the left ventricular outflow tract, you can see the thickening and shortening of the chordae, so they just don't give you the room to play with, and then anything you do that's going to put strain on these areas is also going to change the shape of the ventricle. So very complex. This is what it looks like under the scope. On the left, this is the valve, but on the right, the chordae, and they're both surrounded by this fibrous tissue. And then finally, I just want to leave you with an image of the calcification. It can be very different in the mitral, and it may not only be the leaflet, but it can be the annulus that's markedly calcified. This is also going to be a challenge with deployment, just like we saw in the aortic side. And thank you for your attention.